Hello and welcome to ID Talk, Answers from an Infectious Disease Expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and leader at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of September 21st, 2020. The United States has over 6.8 million cases of COVID-19, with almost 200,000 deaths from COVID-19. Here in Arizona, the numbers are also quite significant. Patients aged 0 through 20 years of age, which is how they're recorded through Department of Health Services, account for 13% of the total cases of COVID-19 cumulative so far. Also, that rate comes out to 1,482 cases from 0 through 20 years age per 100,000 persons aged the same, 0 through 20. This far exceeds the national average of 980 COVID pediatric cases per 100,000 children. The mortality numbers, fortunately, in children remain quite low. And in Arizona, we are currently at 10. At one point, we had listed 12 children who had passed away from COVID-19. However, my suspicion is that 2 of these have been recategorized in terms of cause of death. So we certainly are dealing with a significant burden, and therefore we have plenty of questions going forward, most especially how is the state doing today? And overall, the numbers are thankfully decreasing. Our metrics are improving, certainly in terms of a return to school benchmarks, but there are, of course, still continued point outbreaks or point sources, most notably here in Tucson at the undergraduate campus of the University of Arizona, where some of the young adult students have forgotten their social responsibility training or something like that and have precipitated a mini cluster of cases. However, steps are being taken as we speak to bring these under control, and hopefully, maybe, perhaps, our numbers will continue to go in the correct direction. So, to the questions this week, again, a wonderful list of some great questions. We'll start off with the clinical one, having to do with the experience of COVID-19 and MIS-C, multisystem inflammatory syndrome in children, and its presentation as a cross between toxic shock-like syndrome and a variant or incomplete Kawasaki's disease. The question has to do with the ongoing information or hypotheses about etiology of Kawasaki's disease. And certainly prior to the COVID-19 outbreak and this association with MIS-C, there was significant in vivo and in vitro evidence to suggest that a respiratory virus of some sort might actually be the inflammatory or infectious trigger for the inflammatory vasculitis, which causes the symptoms of Kawasaki's disease. Now it's very possible that we can start to put a little bit more clear name or at least species on that virus, since previously it did not meet the molecular phenotype, if you will, of any known virus. Keep in mind, some excellent research coming out of Stanford by Dr. David Relman suggests that as of today, or even the last 5 years, we know about or have identified fewer than 5%, that's 5% of the total infectious agents to which we may be susceptible. So it's very likely that there are respiratory viruses out there yet to be described, determined, and named, and at least one or perhaps a cluster of them may be the infectious trigger for Kawasaki disease. The new experience now with MIS-C and SARS coronavirus 2 suggests that this virus is at least one of those numbers which has the potential to precipitate such a reaction. Now, it's not a 100% attack rate, so there has got to be some sort of susceptibility, whether it's genotypic or immunodeficiency related, but at least this is a step in the right direction to try and better understand, now in retrospect, what happens to cause Kawasaki's disease, the classic or even the variant form. So stay tuned for that, an exciting area of research growth, I believe, and we will hopefully know more even in the next coming months or so. Next set of questions has to do with preventative steps, and especially as we look at school children returning to school, and also with changes, hopefully, in the environment, like cooler and drier outside. What does this mean for the possible aerosol transmission of SARS coronavirus 2? A bit of a backstory, keeping in mind that in the early days, and here we're talking winter of 2019, early 2020, there was a strong suspicion that SARS coronavirus 2 was transmitted only by respiratory droplet. However, there is emerging both scientific and also bioepidemiologic evidence which strongly suggests an aerosolization component of the transmission of the virus itself. Makes sense. It totally makes sense because we know that no respiratory virus is purely transmitted by one mode versus the other. So with that in mind, what does the research tell us about methods to mitigate an aerosol transmission specifically? What about the potential of a HEPA filter? Certainly, most HEPA filters have a small enough micron size that they could filter out the SARS coronavirus 2. And similarly, what about other environmental controls such as ultraviolet light or heat or cooling or topical drying agents? All of these make perfect sense. And certainly the virus, as an encapsulated virus, is susceptible to environmental extremes such as UV light and including ultraviolet light A and B, such as is obtained in sunny southwestern Arizona. That all makes sense. The challenge, of course, is how to use these modalities effectively in terms of a placement issue or return on investment. How do we place these in the schoolrooms? How do we place these in our clinic spaces, especially in buildings that are not set up to have the airflow necessary for true environmental and infection prevention techniques? So it's a great suggestion. I wish that we could just sort of retroactively install HEPA air filters inside every air handling system in the state. That would be fantastic, not reasonable. What about trying to do so in our clinic space? Well, it also makes sense. The challenge is not so much the filters themselves, but how many air exchanges occur within that clinic room. So simply filtering the air, if there's only 3 air exchanges per 30 minutes, is nowhere near adequate to prevent aerosol transmission from an infected patient to one of us or to others in that room. Perhaps the best model to take here are the respiratory physiodynamics which come out of operating theaters, where they have typically downward airflow with around 25 to 30 air exchanges per hour. That's significant. If one could somehow install an air handling system to create that kind of airflow, one would actually probably not even need the HEPA air filter if that air were exhausted outside, or certainly performed in a negative airflow room. So realistically, yeah, HEPA filter is great, UV light's great, heat, great, if it were possible to install those in a cost-effective manner in every single living environment, school environment, clinic environment possible. What about specific sites? And especially if in our clinics or in our emergency departments, we have a procedure room where an aerosol generating procedure occurs, such as perhaps we've identified a room in clinic where we swab the patients with the nasopharyngeal swab, looking for SARS coronavirus 2 or for other respiratory viral pathogens such as influenza, RSV, etc. What about the aerosolization room if we're giving nebulized treatments to our patients with asthma or who come in with wheezing? There again, if it were possible to create such a room and turn it into a negative airflow construct, that would be great. That would be very helpful. However, I suspect that most of us are not practicing in buildings in which that's realistic or even doable unless one were to do a major renovation, which is going to cost a whole bunch of money. So in the interim, would bringing a portable HEPA air filter system and putting it into a point source room, such as the aerosol room, the swabbing room, would that help? Theoretically, and based on no evidence whatsoever, I think it might help somewhat, actually. I don't know if it would justify the cost of one of those units, but if you happen to have an extra HEPA filter system, which is portable, lying around, put it in the clinic. It won't hurt, that's for sure. It may actually help. A couple questions then about personal protective equipment, and especially those of us who wear glasses, readers or otherwise, and especially glasses with progressive lenses. So how do we, or are there possibilities to combine use of a face mask, a face shield, and goggles that could be worn with glasses? I will admit I've not made an exhaustive survey of all the products out there, but I would imagine that it's very difficult to find any one product which combines everything you need, which is also immune to the fogging problem. I personally am fortunate to only have to wear readers, but I gotta wear readers if I want to see the computer and the patient. I have found goggles that have readers built into them, and those are easily searchable online. Perhaps the most effective then is going to be use of the normal glasses such as we wear, use of the normal face mask with the glasses bridge put over the top of the face mask to try and avoid fogging. And then one of the clear shields or clear plastic shields, which hangs down from a headband, to provide a physical barrier. That seems to be the most commonly used combination. It certainly has been used effectively in the hospital I work at. But all I can say is, and I'm sorry about this, but personal experimentation is probably the best way to find what works. Similarly, for the N95 masks, there are now about 3 quadrillion, well, that's a rough estimate, products out there, and certainly far more than the original 2 or 3, like the duck bills and that blue mask that we all sort of grew up, doing our fit testing. There are many more products out there, and some fit better than others. I personally have a short goatee slash mustache, and I have to keep it trimmed very short to be able to fit test my N95 masks. Other facial structures just don't seem to fit very well at all. So for those individuals, there are the sort of contained negative airflow systems, which are burdensome and onerous because you have to wear a battery pack and it's a major pain to wear. But yet, if that provides protection in a highly infectious agent such as SARS coronavirus 2, then I would suggest to us that that's what needs to happen. A lot of questions about when and how do we test. And for these, I blame with gentle affection the beloved CDC that's been having a really rough time. I'm not going to go into the backstory or the politics, because I imagine we all have theories and hypotheses about these. But suffice it to say that CDC has had a very much on again, off again, on again challenge with its recommendations, including, by the way, today an immediate take backsies with an unvetted report or recommendation to prevent or to put aerosol protection mechanisms in all airspace rooms. That was rapidly retracted because it had not been completely vetted. So what about testing? Should we be testing or screening asymptomatic exposed people? Yes, we should. That at least finally the CDC has been able to come out in favor of, despite a rapid retraction of the initial recommendation. So how often and when do we test? So sure, I suppose there'd be benefit if we could test every single individual in the entire community every single day, but that's not going to provide a whole awful lot of additional benefit to doing the official contact tracing investigation, which is index patient identified in, we'll say, the home setting. Every individual who lives in that home, and we're talking even if they try to avoid the room where the index person is staying, every individual is screened once during that exposure event, if you will. And it can be as soon as the index patient is identified, because theoretically, for the index patient to develop symptoms, submit swab testing, and be diagnosed as being a COVID-19 case, they must have been contagious for a minimum of 3 to 4 days and likely longer prior to that test result being acquired. So, individuals living in the house or spending time in the house with the index patient for the preceding 3 to 4 days or week, if you will, likely had a sufficiently significant exposure to acquire COVID-19 if they're going to, or not to acquire if they're not going to. So, testing all the contacts within a household as soon as the index patient is diagnosed is appropriate, and then further interventions based on the screening test results. One question specifically asked, do we test all children in the home if the parent is tested positive? Yes, we do. When and how often? We test all the children as soon as we get the parent's positive result communicated to us, and just that one time. Now, the children in the household of that index parent case will still require to self-quarantine for 14 days after their last exposure to the parent. So theoretically, we covered this last time because it's quite confusing. Theoretically, index patient index parent, for example, turns positive and immediately self-quarantines inside the house, we screen all the children, all the other contacts in the household at that time and instruct the contacts, the children, etc., to not be exposed to the index parent. If that is able to happen, and I know it's near impossible, but if that is able to happen, then the contacts, the children in the household, need to be quarantined for 14 days per the CDC recommendations. It's very complicated, and for all we know, the recommendations will change once again, but what I've just described to you seems to be the most reasonable approach. Okay, what about the cases where we have an exposure and then the child has a fever? Okay, great. Well, that's a concern for the child then having COVID-19. But what if they have a clear alternate diagnosis as a cause of fever? For example, otitis media. And this is one of those classic, common pediatric infections that's going to occur regardless of a preceding viral process like SARS coronavirus 2. If the child has been exposed to a known index patient and has a negative screening test and then develops fevers within 4 days of the negative screening test, and the fevers are caused by clear evidence of otitis media or streptococcal pharyngitis or sinusitis or something which we can pretty comfortably hang our hats on, then we would not need to retest the child, and we would still have to do the normal quarantine or isolation process from the exposure, but at least it would not have to be extended in any way. However, what about a child who has no known exposure? So perhaps they're in daycare, kindergarten, elementary school, whatever, but they come to the clinic with fever and you see evidence of otitis media on exam. Do you also need to test them for SARS coronavirus 2? Realistically, well, you're going to quote me on this, but I'll say it anyway. Realistically, probably not. But without testing that child for SARS coronavirus 2, even with an alternate diagnosis, we cannot be at all confident that they do not have dual infection. So I would suggest to you, especially as resources currently are quite robust in screening tests and kits, I would suggest that regardless of alternate diagnoses, that we test our patients also for SARS coronavirus 2, because certainly they can have dual infection, and it'd be easier to be more comfortable in removing isolation for a return to daycare, kindergarten, school, etc., if we knew they were SARS coronavirus 2 negative by screening test and we had an alternate diagnosis. What about the tests that are out there? And certainly you've seen continued rapid approval of multi-tests, of antigen tests, of the PCR tests, the antibody tests. Right now, the FDA is reserving approval for tests that have a sensitivity and specificity of at least 90% and realistically in the mid-90s or so. That's pretty decent. Is it 100%? No, of course not. And there are very few tests that are going to be that way. So it's reasonable to use what is available on the market, which or if it has been approved by the FDA, to be part of your sensitivity and specificity approach to screening patients. Okay, let's turn now to vaccinations. So I think we've all seen a fair amount of the news in the media regarding current status of the vaccinations. There are worldwide 8 products which have entered phase 3 trials. This is globally. And in the United States, there are 3 or perhaps 4 products which are currently recruiting for phase 3 trials. 2 of those products are the messenger RNA messenger RNA vaccines. The other 2 then are replication deficient viral vector, typically adenovirus, as a way to expose the vaccinee, the human being, to the SARS coronavirus 2 spike protein. Unfortunately, of all the phase 3 trials and all the vaccine research, there has not been research performed in patients under age 18. Specifically, age less than 18 is an exclusion criteria for the vaccines currently recruiting in Arizona for their vaccine trials. That's unfortunate because, of course, we know that children are not innocent in terms of being able to transmit the virus. Children less than age 10 are less likely to transmit SARS coronavirus 2 than are their older child colleagues, age 10 through 19, and adults, but they are not unable to, sorry for the double negative, but children less than 10 can transmit the virus. So it would be fabulous if we had vaccine research for kids under 18 to help us use those vaccines with comfort. My sense is, however, that the major push is to get the adult vaccine indication first and then to do the pediatric research. Wow, this is a difficult issue because you might suggest, well, let's just, if it's safe for adults, it'll be safe for kids. Let's just immunize everybody based on the adult data. I personally, and as a clinician scientist, would be uncomfortable with that for the exact reason that another questioner has posed, which is this is a fast-tracked novel mechanism of vaccination, that being the messenger RNA approach. Scientifically, it sounds great. It makes a whole bunch of sense, and it seems like the time has come for RNA and DNA vaccines to take up national or international prominence. The problem is we're trying to get indications, safety, and efficacy data done in a rapid fashion without long-term data to prove the safety. So it is a very difficult step to just blindly, because that's what it is, open up vaccination of children less than 18 to such a vaccine product without having some degree of safety studies done beforehand. So it's going to be a while. All the vaccine products out there require a minimum of 2 doses separated by at least 3 and more like 4 weeks. Several of the live attenuated vaccines that are being tested in China require 3 doses. The products that are being tested here in the States are all a 2-dose vaccine series split by 4 weeks or so. So even if we were to somehow get a magically approved vaccine in the next month, it would still take minimum of several months, more like 4 to 5 months, to manufacture enough doses to immunize at least a significant part of the population, and then we'd still have to vaccinate them a second dose. So we're looking at a half year to try and theoretically achieve herd immunity. A question: what percentage of the world population would it take to be vaccinated to fully protect against COVID-19? I hate to answer this because the answer is not going to be very nice, but current estimates for a vaccine which is 75% effective, would require a minimum of 2/3 of the population to be vaccinated. Now that's a very, very liberal estimate. It would likely take far more than that, keeping in mind that the FDA is prepared to approve a vaccine which is only 50% effective. The modeling with that would suggest that we would need to vaccinate upwards of 90% of the global population, the world's population, to achieve anything resembling herd immunity. Last estimates are that nearly 50% of Americans are now by poll saying they would not get the vaccine if it were offered for free today. That's, up from 40% 2 weeks ago, and certainly up from only 25% several weeks before that. So the current scientific messaging, unfortunately, is going the wrong direction, and the likely uptake of a vaccine, even if it were approved by FDA, even if it were given free, even if it were available on our doorsteps tomorrow, the uptake is going to be abysmal. So I think it is highly unlikely that a vaccine intervention in the States or elsewhere in the world is going to be successful as a solitary intervention to stop the spread of COVID-19. And this has actually been stated by Doctors Fauci, Offit, others who know what they're talking about, and I'm just merely quoting what their concerns are. So we got some problems. Vaccine is going to be important, yes, it will, but in combination with the social hygiene, such as distancing, limiting exposure, masking, we're not done with any of this yet, I think, for the foreseeable future. One of the questions, and this is to carry on with the vaccine and concerns about vaccination of a rapidly approved and perhaps poorly tested or fast-tracked vaccine, I really appreciate that this question. It's like, what arguments do I have to convince concerned physicians and other medical professionals that we can be safely and effectively vaccinated when a COVID vaccine is available? This is a fabulous question. And my short answer is, I don't have any arguments to convince us, because it would be trying to support a product that we don't know the long-term outcomes for. What I can offer, and this is probably, well, it's not going to be sufficient. But what I can offer is to point to the rigorous approach so far of the pharmaceutical companies and scientists who are not politically affected in holding the vaccine discovery, the studies, the recruitments, and the outcomes to an appropriate degree of scientific rigorousness. And I point to the recent experience with AstraZeneca that very appropriately paused their study of their replication efficient adenoviral vaccine based on one patient in London who developed transverse myelitis. That was noted to be a serious, potentially adverse effect. The entire study globally was halted while an independent review board looked at that case. Ultimately, the review board determined that the vaccine, because indeed that patient with transverse myelitis received the vaccine, but determined that the vaccine was not affected or was not associated with that complication. There's been one prior patient also in the AstraZeneca product that had developed transverse myelitis, and that was in a phase, I think, 2 trial. But that patient also, as it turns out, was diagnosed with multiple sclerosis preceding vaccine receipt. So the risk is low. However, the process, I think, worked. And despite, huge clamoring for a vaccine performed and available yesterday, I applaud AstraZeneca and their scientific director for the courage to halt the study while they determined if there was or was not a negative consequence. Have we seen that data in the United States? Not as of last I checked. And so the US arm of the AstraZeneca trial has not yet restarted. However, it sounds like that is in process, and we can see that vaccine start up again in the near future. So that is just one example. Also, I think we all saw in the media that the 9 pharmaceutical companies that currently are involved with active vaccine research for COVID-19, their directors, CEOs, whatever, created a consensus statement saying that they would agree not to release a vaccine until it had satisfied rigorous scientific assessment, trials, etc. And this was in direct response to some calls politically to have a vaccine ready in the next several weeks to month or so. So that kind of blew my mind. Yes, I am as cynical as the rest of us, I believe, and it is really good press to be. We are all in support of population safety, et cetera, and that's fantastic. But it also makes sense. My worry is that, and I hope that's what these pharmaceutical companies were addressing as well, that if we were to release a vaccine and it were to have unexpected negative consequences, that would be the death knell for ongoing vaccination, not just for COVID-19, but for additional vaccine products, which, as we know, are completely critical. So back to the question, do I have arguments to convince us to receive a vaccine which has been fast-tracked and for which there is not a long-term safety study? All I can offer is that it's a hope that the rigorous discovery will be as rigorous as it would be for other new vaccine products, and all vaccine products had to get started sometime. That's one. Two, I think personally, as a health professional, I need to accept some degree of risk so that I can provide messaging to my patients in a way to, I hope, combat this otherwise uncontrollable pandemic, which is having huge impacts on health and safety of our patients for other reasons. How many of us have had patients who failed to come in for routine vaccination? How many of us have had patients who have developed or en route significant psychosocial concerns, suicidal ideation, depression, anxiety, you name it? How many of our patients have been unable to contact us for necessary preventative and supportive care because of the pandemic? A large number, of course. So if there is, even with a degree of personal risk, something that I can do to convince every of my patients to be vaccinated, that's a step I would take. That actually, and this is not the Sean show, although I guess it is, but I volunteered for and have been immunized as part of the Moderna vaccine trial, and I received vaccine. So I'm hoping the messenger RNA vaccine is safe. I guess I'll find out over the next several months to years. But certainly my motivation was to try and support the scientific approach. But is it totally safe? I cannot say that. I don't know. So that, I think, is where we're at. A whole bunch of great questions. I don't want to take too much of your time. Keep those questions coming. And as always, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to COVID, that's COVID, at azaap.org. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit azaap.org. Thanks for listening, everybody. Stay safe, stay passionate.